Oral Health and Diabetes.
Series 13.
Welcome to Oral Health and Diabetes. I'm going to be speaking today about the relationship between oral health and diabetes. More than 900,000 Ontarians currently are diagnosed with diabetes. This is 20% more than in 2008. Over the age of 75, the prevalence is between 15 to 20% in Canada. In most long-term care facilities, people with diabetes make up at least a quarter of the resident population, and this figure appears to be increasing. The growing prevalence may be due to more newly diagnosed cases and or persons living longer with diabetes. The risk of oral complications increases with age, as does its potential to adversely impact systemic health. Severe periodontal disease occurs in 14.8% of people aged 60 to 79, and 22% of people aged 60 to 79 are edentulous or without teeth. Oral inflammatory disease affects up to 75% of the diabetic population. Oral health is often referred to as the sixth complication of diabetes. Periodontal disease, or gum disease, is one of the poorly recognized complications of diabetes. Poor glycemic control may be a risk factor for periodontal disease, and periodontal disease may have an adverse effect on glycemic control, thus the bidirectional relationship. Complications can include periodontal disease, or gum disease, dental caries, xerostomia, or dry mouth ulcers and lesions, an increased risk of oral infections such as thrush or angular colosis. Firstly, let's look at periodontal disease, or gum disease. The bacteria in dental plaque irritates the gums and causes infection, to which the body responds by causing the gums to become red, swollen, and bleed easily. Gingivitis, or early gum disease, rarely causes pain and discomfort, and therefore it is particularly important that we be aware of even slight changes in gum tissues when caring for the older diabetic patient. If gingivitis or early gum disease is left untreated, then it can quickly develop and progress into more advanced, irreversible stages of periodontal disease, which results in irreversible bone loss and eventually tooth mobility and even tooth loss. Periodontal disease, what is it? It is caused by bacterial plaque, an infection that attacks soft tissue, destroys attachment fibers, and alveolar bone that holds the teeth in place. Severity and extent of the periodontitis is multiplied by the presence of diabetes. Persons with diabetes, type 1 and type 2, experience both gingivitis and periodontitis at much higher rates. What should we be looking for? Periodontal disease, or gum disease, is characterized by poor oral hygiene, resulting in redness, swelling, or bleeding gums. If left untreated, it may progress to a more advanced stage of gum disease, leading to the destruction of the alveolar bone and eventual tooth loss. A supporting bone is lost. Other indicators of the presence of gum disease are gum recession, chronic bad breath, the presence of pus, and of course, in more advanced stages, tooth mobility. Periodontal disease in its early stages rarely has pain involved with its presence and may therefore go undetected, unless regular assessments take place. There is little or no difference between the bacteria present in the periodontium of diabetic patients and the bacteria present in non-diabetic patients. But, however, diabetic patients, both type 1 and type 2, encounter gingivitis and periodontitis at a much higher rate than the non-diabetic. The reason being is that the diabetic client has a compromised immune response to the disease process. This is reason for concern. What is the concern for older adults with diabetes? Inflammation and infection that occur during periodontitis can create a chronic inflammatory burden systemically, which makes it even more difficult for the already immunocompromised older diabetic adult. What is the concern for the older adult with diabetes? A vicious circle. Periodontitis may worsen diabetes, but due to the over-response of inflammatory regulators in the body, this in turn can lead to poor glycemic control, which leads to greater inflammatory response in the gum tissue, which leads to further destruction of the bone supporting the teeth. Diabetics have a higher prevalence and severity of gingival inflammation and periodontal destruction. Also, the beneficial growth factors are inhibited, interfering with the body's healing response to infection. Periodontal disease is inflammatory in nature, and as a result, it can negatively impact glycemic control. The severity of periodontal disease increases as A1C levels rise. Inflammation and infection that occur during periodontal disease leads to a chronic inflammatory response, which burdens the older diabetic client systemically. Periodontitis is more severe and rapidly progressive in people with diabetes compared to people without diabetes. People with diabetes are at increased risk for destructive periodontitis, which is severe inflammation of their gums. In addition, untreated periodontitis in people with diabetes may complicate their glycemic control and is associated with heart and kidney disease. Regular dental visits provide opportunities for prevention, early detection, and treatment of periodontal problems. Research has confirmed that improving oral health knowledge is a necessary prerequisite for implementation of proper oral self-care behaviors. Although knowledge of appropriate oral behaviors does not necessarily translate into practice, lack of necessary oral health knowledge may increase risks of diabetic oral complications. Misconceptions or misinformation about oral health may actually lead to harmful behaviors. Instead of brushing and flossing more often, people with diabetes may believe they should stop brushing and flossing when their gums bleed. People with dry mouth may not know that using mouth rinse with alcohol in it to improve oral hygiene actually increases the dry mouth. And prevention of oral complications, as well as effective management of these conditions for the older adult with diabetes, is of paramount importance to improving their overall health. This is where we as healthcare professionals can intercept the cycle and make a difference through education and awareness. The good news is periodontal disease can be treated, and with the treatment and prevention of periodontal disease, there is a better chance of improving the overall health of the older diabetic client. As with any infection for the diabetic client, gum disease can have a negative impact on glycemic control. Infection of the periodontium can create an ongoing inflammatory burden on the host system, triggering a chronic cycle of inflammation and infection. Clinical therapy begins with the elimination of inflammation. When periodontitis is treated, diabetes disease parameters improve and vice versa. Xerostomia as a complication of diabetes occurs as the salivary glands of the diabetic client slowly degenerate over time until they can no longer produce enough saliva to maintain the healthy balance needed for optimal oral health. Webinar series number 11, Xerostomia, provides more information on dry mouth assessment and treatment. Many older adults living with diabetes are at risk of xerostomia. Firstly, because many medications used to treat diabetic complications can trigger the degeneration of the salivary gland, can also create dehydration relative to hyperglycemia. And the longer a patient lives with diabetes, especially poorly controlled, the greater the risk of developing degeneration of the salivary function. Impaired glucose management relates to the peptide salvapan found in human saliva, which is believed to lower blood sugar after meals and to aid in blood sugar normalization. This occurs through glucose-stimulated release of insulin. So when salivary function is inhibited, glucose levels may rise and make management more difficult, perhaps creating even greater dependence on diabetic medication. So what should we be looking for? Sticky, dry feeling in the mouth and throat, frequent thirst, mouth sores and split skin at the corners of the mouth, a burning sensation in the mouth, especially the tongue, problems speaking due to the dryness, difficulties in tasting and chewing food, and in swallowing due to the lack of saliva, hoarseness and dry nasal passages. Bad Breath Webinar Series number 8, Halitosis, can provide you with more specific information on bad breath assessment and treatment. Xerostomia care interventions can include saliva replacement therapies, medication review, a twice-daily program of good oral hygiene, best practice guidelines, closely monitored A1C levels, regular examination by an oral health professional, use of a room humidifier, and drinking plenty of water. So in summary, we need to understand the relationship between oral health and diabetes, recognize oral changes, and encourage or provide twice-daily oral hygiene care regimens. We need proper diabetes management and referral and regular oral health professional checkups. For more references on oral health webinars, see the following slides. A collection of the best practice guidelines, websites, and a variety of articles are assembled at the end of this presentation for your reference. Thank you